I think let's start. Thank you all. Welcome you to our first Doc Talk of this year, and we have with us Dr. Bridget Keenan from UCSF. So a little bit about her. She attended Johns Hopkins for her MD PhD studying immunology and pancreatic cancer tumor immunotherapy. She completed her internal medicine residency at UCSF and is a hematology oncology fellow. She's a clinical fellow in Dr. Lawrence Fong's lab, working on tumor immunology and immunotherapy for gastrointestinal cancers. She works on liver, gastroesophageal, and CRC cancer with the goal of understanding the response and resistance to immunotherapy, including vaccines, checkpoint blockade, and novel immunotherapy combinations. So Dr. Keenan, thank you so much for your time and for doing this. Welcome.
All right, thank you. It's so nice to meet everyone over Zoom today, and thank you for that introduction. As you can see from my slide, I'm going to be talking today about colon cancer, colorectal cancer, and immunotherapy. And first, I just want to get a couple disclosures out of the way, and then I will go ahead and start my talk. So first, I just want to say that I have no relevant financial disclosures today that pertain to this talk. And also, I'm here on behalf of myself, not officially as part of UCSF, but as Dr. George said, I am an oncology fellow at University of California, San Francisco. Today, I'm going to focus on three main areas. And after each section, I'm going to stop, just do a quick check-in to recap all of these areas, because this is pretty complicated material. And I know that people are coming from a range of different backgrounds. Some people may have heard a lot about this, and maybe that perhaps some of this are new topics. So first of all, I'm going to talk a little bit about the immune system in cancer. And in order to talk about why we want to use immunotherapy to fight cancer, we actually have to get a little bit into how the immune system works. So I'll try to keep that as basic as possible, but we will just talk generally about some of the cells in the immune system. The second part of my talk is probably what everybody wants to hear about the most, which is colorectal cancer and immunotherapy and what the treatment options are. And in order to talk about that, I'm going to be talking about a feature called microsatellite instability that really affects whether colorectal cancer responds or doesn't respond to immunotherapy. And then I'll talk about some of the current options and things that are on the horizon and are in clinical trials right now. And then finally, as I start to discuss some of those new and exciting options in clinical trials, I'll talk about different kinds of immunotherapy. So first, to start out with, I'm going to talk about why we would like to use immunotherapy. And actually, my anecdote to begin with is a little bit, just a tidbit of history for today. So it turns out that immunotherapy is not actually a new idea, and it is an idea that has been out there for over 100 years. This is an excerpt from the New York Times in 1908. And you don't have to, digest this whole article or what they were trying to do here, but I can tell you a little bit about the story. And so there was a surgeon named Dr. Coley who was working in New York, and he was treating patients with sarcoma, a type of bone and muscle tumor. And as he was a surgeon, he would remove these tumors, and back in the early 1900s, there wasn't very good hygiene. So actually some patients would get post-operative infections that we're much better at preventing today. However, he noticed when patients got a post-operative infection, sometimes they actually did better in terms of their cancer. So that would stop the cancer from coming back. And based on this, what he noticed, he decided that he would actually go into the lab, mix up some bacterial toxins, so take parts of these bacteria, and actually purposely infect the wounds of patients. And he had some success with this, but there were a couple of problems. One was that, this was, first of all, a pretty wild idea that was pretty out there, and so it didn't gain initial acceptance. The other thing is, this is before there were a lot of protections in place for patients, and really before we had the kind of clinical trials we have today that really standardize things. So other people had tried to repeat this, but there wasn't a formal recipe for this bacterial toxin he made, and it just wasn't able to be repeated, and didn't really have the degree of evidence that it needed to be widely accepted. However, the idea was when these patients were getting these inflammatory responses from a wound infection, what was happening is actually their immune system was being turned on against their tumor. And the wake-up call was this infection or these bacterial toxins that he was injecting. And so that really started off, over 100 years of research. And while his idea didn't take off then and there, his daughter, who was not a physician, actually took over his idea and made an institute for it that exists today called Cancer Research Institute. I'll talk a little bit more about that later in some of my other slides. It's another great organization. So we've come a long way since then, and that's just sort of my interesting tidbit to start off our talk and get people interested. This is just, sort of an overview slide to show that now in 2021, we have many different kinds of immunotherapy. We've moved way past just taking some bacteria in the lab and injecting it into patients' operative sites. And we've really come very far. And that's going to be the focus of the talk today, to talk about what some of these new therapies are. As I mentioned, immunotherapy's come a long way. So as Dr. George said, I got my PhD in immunology at Johns Hopkins. And around the time that I was starting, there were only a couple approvals for melanoma and for kidney cancer that used immunotherapy. Flash forward to a couple years ago, and in fact, I need to keep continually updating this slide because it's changing all the time. And now instead of 2 FDA approvals for drugs to treat cancer with the immune system, we have over 10 and probably more like 20. And 2 of the important ones I added at the end that we're talking about today is that while colon cancer is not actually on this list of diseases that has a disease-specific indication to use immunotherapy, there are some colon cancer tumors that fall into these last categories. And don't worry about the details now. I'll definitely go back to those and talk about what do those terms mean, MSI and TMB. I'll come back to them, I'll discuss them in detail, and talk about why immunotherapy and colon cancer are relevant to those terms. This is just to demonstrate there are a lot of different options out there now, and we've come a long way in the past 100 years, but actually just in the past 10 years. As I mentioned, I don't want everyone here to feel like they have to be trained in immunology to understand this talk, but I do want to just talk very basically, about the immune system. So the immune system has many different cell types, and you don't need to know all of these kinds of cells, but there are a couple in particular that we're going to talk about because we're using them actually as therapy to treat cancer patients. The other takeaway I want to have from this slide is that there are many kinds of immune cells, but they fall into 2 major classes. The first here on the left, or in this purple color, these are early immune cells. They go by a lot of different names, and I'll talk more about them in another slide. They're the very first cells that respond when you get a splinter under your skin, when you have a cut, or somebody sneezes on you. And before the days where we were masking and there were potential to get a lot of colds and flus. Well, those are the first cell types that see a foreign invader like a bacteria or virus, and in some cases actually cancer cells, and starts a response. But ultimately, we need another part of the immune system, and that's that part over here in this orange color. Mainly 2 different cell types, B cells and T cells. And those are the cells that end up sort of coming in on the tail end of immune response and helping that immune response persist for a very long time. It actually is what we call memory. So, we get the flu vaccine, and then months later, our body might actually see the flu when somebody coughs or sneezes on us. And because we've gotten that vaccine, even though it's months ago, those B and T cells remember. They have a preformed response, and they can be able to eliminate that, keeping us from getting sick. So I circled some of these in particular. And we've actually, as immunologists, we've been able to take these cells and optimize them and try to use them to fight cancer by engineering them. So again, we'll talk more about this, but we've actually found a way to take out patients' T cells, engineer them, and give them back to them to fight cancer. That's called cellular therapy or T cell therapy. I'll talk more about it in the third part of the talk. And the other thing we've used are these proteins called antibodies. They're produced by the B cells. And antibodies are basically proteins that bind to other proteins. They're really good at sticking on to things. And again, I'll talk about how we've actually used these to engineer them to fight cancer. The other thing I want to say, again, without getting too detailed about how the immune response works, is there is this concept called MHC or HLA. This is the way that T cells specifically recognize a foreign particle. And actually in the context of cancer, this could be a cancer mutation. And so T cells have these receptors on their surface called T cell receptor, or TCR, and they bind to this foreign particle, not by itself when it's sort of floating through the bloodstream, but also when it's being presented by another cell type. Those are those early cells I talked about. These are called antigen presenting cells. And they have these proteins on the surface known as MHC or HLA. They're kind of similar terms, and I will talk about them in the next as well. See, now I have my laser pointer up so I can point to this. So this A here represents like a foreign virus, bacteria particle, or even a mutation from a cancer cell. And the MHC is how the antigen presenting cell is turning on the immune response to that. So this is a pretty complicated slide and a pretty complicated idea, but the take home here is that everybody, what I'm going to talk about in the next slide, so everybody has different HLA or MHC proteins. There are a number of different classes of these, and for each class there can be a number of different genes. So what that means is that there's actually thousands of different possible combinations, and that actually means that everybody's immune system is a little bit different. When you get a vaccine, everybody has the potential to respond to that, but everyone's going to respond in a slightly different way. And the same thing with vaccines, infection, cancer, etc. I'm bringing all of this up and harping on this kind of complicated idea because of these different HLA types that are different across patients and individuals. Immunotherapy sometimes need to take that into account. And instead of just making one drug that can treat everyone, we need to make a very specific drug that works with a patient's HLA type. That's pretty complicated. I'm going to move on for now, but I am happy to come back to that when I talk about different kinds of immunotherapy in the third section. And again, I put a lot of details in this slide. I don't think that not everyone needs to get a PhD in immunology from this 1 hour talk, but they're just these different types, and there's some of the names of them are A, B, C, DR, GQ, DP. These are just different codes for the different combinations that an individual can have. So I'm going to talk more now and focus on what are the pros and cons of immunotherapy. I think this is probably the highlight for a lot of people. So I already talked about how immune responses are very specific. They're different for every person. And the cool part about the immune system is it really has the potential to recognize anything, any foreign invader, any virus, bacteria. It can adapt, even if when we're born, we actually don't have all these immune system responses in place. We have to adapt and form those immune responses over time. So even as adults, we can form new immune responses, including to cancer. And even though cancer cells look like a lot like our own cells, they can have these mutations where it's a normal protein gone wrong. So something has changed in the cancer cell, and that's our potential where we can, if we can get the immune system to recognize that difference between a normal cell and a cancer cell, we can have an anti-cancer immune response. And even though each T cell or B cell might recognize just one mutation, we have thousands and hundreds of thousands of T and B cells, all individually recognizing different things. So that means we could actually have the potential to respond to multiple tumor mutations, not just one or two. I already talked about responses can be long lasting. Once an immune response is initiated, it can last for a long time. And, I say this last point with a grain of salt, that there's potential for less side effects. And really, I wouldn't quantify this as less per se. I would actually just say that the side effects are very different than chemotherapy or radiation. And I'll talk more about that. So, maybe some of the patients here have already experienced things like chemotherapy and radiation. These can be really tough treatments on the body. The side effects are pretty typical. So really common ones are things like fatigue, nausea, vomiting, hair loss. The immune system works very differently, so these are not the side effects of immunotherapy. However, there are potential to develop side effects on immune therapies. And these side effects are the result of a very tight balance between protecting us and then creating too much inflammation that spills over and can affect normal cells. So when the immune system is very turned on by these immunotherapies, and I'll talk more about what some of the kinds of immunotherapies are at the last part of the talk, it can actually create this inflammatory response. It's really similar to a discussion I'm having with a lot of patients now about the COVID vaccine, because people are hearing about these side effects. Like a day afterwards, they feel kind of crummy, they have fevers, they have chills. That actually could happen with other kinds of immunotherapy, like cancer immunotherapies as well. And what that is actually your body's immune system is just revving up. So it actually is not an infection itself that is causing the fevers. It's just that the immune system is getting very potently activated. And usually those responses, those effects are transient. So after getting a cancer vaccine or an immune checkpoint inhibitor, all kinds of treatments that I'll talk about later, you can have a couple days of this fever, chills, fatigue, etc. Then there's another kind of side effect that can happen with immunotherapy. And this is similar to the concept of autoimmunity. Autoimmunity means that the immune system has attacked itself. I mentioned that cancer cells can look similar to normal cells. So sometimes when we turn on the immune system against cancer, we also turn it on against itself. And that can mean that specific organs or cell types are attacked by the immune system. For example, if the immune system is activated against your joints, you could get a feeling like arthritis. If the immune system is turned on against the colon, that could result in colitis or diarrhea. So that is very variable, and luckily that is not super common. The things that I talked about, like fevers, chills, feeling a little bit fatigued, those are more common with immunotherapy and usually last only a couple days before resolving. But these more specific things, like having one organ affected, those happen in about a quarter or less of patients that are treated with a kind of therapy called checkpoint inhibitors that I'll talk about. So different than chemo and radiation, where we know that most patients are going to have some degree of side effect, it's very hard with the immune therapy to predict who might have a side effect. So just to recap the first part of the talk, I've gone through a lot of information so far, and I don't expect people to get all of it at once. So that's why I just wanted to take a stop and recap. And here are the major points. So the immune system can be used to fight cancer just the way that it can be used to fight bacteria or viruses. And this actually isn't a new idea. I talked about this is an idea that's been around for 100 years, but we're getting a lot better at figuring out how to use it so it works. Secondly, in part due to these different HLA or MHC types, everyone's immune system is very different. But we do think that everyone's immune system has the potential to respond to cancer. And lastly, immunotherapy works very different than chemo and radiation. So that means it has a very different set of side effects. And we don't know who will get those side effects. They're very individualized, and not everyone gets them. So that's why I said potential for less side effects. We just can't know for sure. So now I'll move on to talk about the second part. And Dr. George, feel free to stop me after the first and second section, or we can wait till the end to go through some questions. But the second part of this is now talking about colorectal cancer and immunotherapy. And I talked about this concept called microsatellite instability and how this relates. So let's dive into that first. So again, a little bit of science just to explain how this works. So our DNA has, it needs to be copied all of the time, every time we make new cells. Every time it's copied, there's a potential for it to make typos and mistakes. Normally what happens is that if there's a typo where you see this little green area that is a mistake, our body has proteins that repair these typos, proofreading. However, what happens sometimes in cancer, and I'll explain sort of how this happens in a moment, is these proteins are messed up or they're missing. And when that happens, the repair process goes awry and you end up with many mutations in a cell. And there's these regions called microsatellite regions, and they're subject to getting a lot of mistakes because they have long repeats of the same pieces of DNA over and over again. Those are naturally occurring, they're in everyone's cells, but those ones in particular are most prone to having a lot of mutations if this process goes wrong. So that's why there's two terms to describe this phenomenon, and they're pretty much used interchangeably. One is mismatch repair deficiency. It's talking about these proteins not being there. And the other one is this term microsatellite instability. And that is referring to the end game. What happens is that there's these areas of microsatellites and now they're unstable. I'm bringing these terms up, so I'll also say, I'll use them, microsatellite instability, I'll say MSI, and the normal condition is MSS, microsatellite stable. These can be inherited or they can develop spontaneously in a cancer. There's a syndrome called Lynch syndrome, and some patients, some people are just born with this in the population. And when you're born with this, every cell in your body is missing one or has a mutated copy of one of those. There's several different proteins that are involved in this process, and one of them is different. So in the setting of a tumor, that can happen spontaneously. But when a patient or somebody is born with one of those mutations, they're inherited, familially, that is known as Lynch syndrome. Either way this happens, it can result in a cancer, in a colorectal cancer. And it turns out about less than 5%, so pretty rare, number of colorectal cancers are actually due to somebody having Lynch syndrome. And people who have Lynch syndrome are not just prone to colon cancer, but other kinds of cancer as well. And then regardless of having this happen spontaneously within a cancer or being inherited from birth, a total, all in all, about 15% of colorectal cancers have this feature where they're MSI high or mismatch repair deficient. And that means the majority of colorectal cancers, 85% or so, actually are the MSS stable kind. The other thing I want to talk about and differentiate from is this term called tumor mutational burden, or for short, TMB. TMB is a measure of all the mutations that are in a tumor. Because people or tumors that have this MSI condition have a lot of mutations, they usually end up being TMB high, lots of mutations. There are a couple other ways that cancers can have this altered proofreading process go wrong, and they end up also having TMB high. So those terms are not interchangeable, but a lot of times they do go hand in hand. So what they found out is that tumors that either have this MSI high or TMB high type respond really well to a kind of immunotherapy called checkpoint inhibitors. Here's a graph of the percent change in a tumor, and the colors are different kinds of cancer. So you can see here, the red ones are colorectal cancers. And you can either look at it from a pie chart, or again, this here is what we call a waterfall plot. So it's the best change in a cancer. If you're a cancer patient, you would want to see your cancer be here on the bottom where it's basically entirely shrunk. And the colors, again, are the cancer type. And so across many different types of cancer that they did this clinical trial in, they saw that there were responses in all different kinds of cancer if they had this feature of MSI high. So that led to these immune checkpoint inhibitors being what I've been using this term FDA approved. What that means is that FDA, the Federal Drug Administration, has seen lots of evidence and they've decided, yes, we should approve this, meaning health insurance will cover it and doctors will recommend it, and this will be the standard of care. So if you haven't heard that term before that I keep saying FDA approved, that basically just means like we have a standard set of drugs that we use for a condition. And in this case, they said, yes, there's a lot of evidence here. We should improve these checkpoint inhibitors that I'll talk about soon for colorectal cancer that has this feature, MSI high or TMB high. Unfortunately, when they did clinical trials for patients whose tumor did not have that feature, patients, remember the majority are this MSS type, 80-some%, they had very, very few responses. And so this is what I'm going to talk about next, microsatellite stable tumors that are also tumor mutational burden low, again, majority kind, there is no approved immunotherapy option right now. There's a lot of reasons and a lot of research going into why these majority of types of colorectal cancer do not respond to immunotherapy. One of the thoughts is this idea of a cold versus a hot tumor. And when I say cold, I mean the immune system is cold. When you look in the tumor under the microscope, we don't see any immune cells. And those are, again, these tumors with the mutations. I think one thing I didn't get a chance to explain yet is why we think the MSI high, TMB high tumors respond is when those have all those mutations in the tumor, it's a red flag to the immune system that something is wrong. So a lot of immune cells that fight the tumor come in. And then when we give an immunotherapy, we're further helping those immune cells, and that's when we see an effect. However, when there's low mutations, there's no red flags to the immune system, and we call that a cold tumor. There's not a lot of immune cells in it ready to fight. There's a lot of other reasons and a lot of research going into this. But unfortunately, just to say, to recap that again, there's no current approved immunotherapy for MSS colorectal cancer. There was recently some hope on the horizon. So there were some small studies in the past year that showed another drug that's approved for colorectal cancer already called regorafenib. Maybe some of you will know about this drug. Was combined with a checkpoint inhibitor. These drugs that I'm going to talk about soon called pembrolizumab and nivolumab. So there was a combination trial, and they put these two drugs together, and they did see some responses. I think it's still early to know whether those responses are better than what we would expect for regorafenib itself, but the small study showed that yes, they do look better than the one drug by itself, and certainly compared to the checkpoint inhibitors by themselves, which really 0% of patients have a response to. But there are more studies needed. Those studies are small, and there's some bigger clinical trials going on right now to find out whether they can repeat that result and if it's a good option. So right now, clinical trials are actually the only real way to get an immunotherapy if you have an MSS TMB low colorectal cancer. And it could be a clinical trial where they're combining something like regorafenib with an immune therapy, or it might be something totally different. And I'll talk about what some of those options are. So just a slide to talk about clinical trials. I know this can be kind of a scary concept and also pretty confusing. I think one of the things I should have also said in the beginning is that I work in a clinical trials clinic at UCSF. Our job is to find the right immunotherapy clinical trials for patients. So I not only see colorectal cancer patients, but patients with many tumor types. However, I'm not here today wearing that hat trying to get people to do a clinical trial. I'm just here to provide information about how trials work and why they might be a good option for some patients, but I want to recognize that they're not a good option for everyone. Some general information about how trials work. So first of all, there's many different kinds of clinical trials. There's what we call early phase trials, and these are phase 1 and phase 2 trials. Sometimes a trial is either phase 1 or phase 2, and sometimes we actually combine them and we just call it an early phase trial, where we're trying to accomplish the goals of phase 1 and phase 2 all together at once. Generally, the idea behind phase 1 and phase 2 or early phase is we're trying to find out about safety, about the best dose or concentration to give. And we also want to get some signs about whether it's working. But like I said, those studies are usually smaller, and it's hard to know for sure how well a treatment works. To find out for sure if a treatment is promising, it goes on to a phase 3 trial. And that's where we compare a new drug and see how it stacks up against established therapy. Now, one point about that is sometimes we don't have an established therapy. Okay, I don't know if my slide is frozen here. Sorry, there we go. So sometimes if we don't have a next best therapy, that could be a placebo. So if there are cases where we do a placebo-controlled trial, or we actually offer things like supportive care, like symptom management, that's the next best thing that we have to offer. It really depends on the situation. So a lot of times patients hear clinical trial and they think, I'm going to be randomized to a placebo. I'm not sure I want to do that. But a lot of times in cancer clinical trials, which are different than clinical trials in general, what I want to emphasize is that it's actually probably more rare to get a placebo in a cancer clinical trial, because our goal is always to help the patients. And if there's a next best treatment out there, we want you to be either getting that or this other treatment that is really promising. So it's more rare actually that we'd offer a placebo, and we're always very clear about whether it's placebo controlled or you're getting something else. In these early phase trials, you're usually just getting the drug that we're treating. It's not a comparison trial yet, so everyone's getting an active therapy. People often want to know how to find clinical trials, and there's a lot of ways out there. I don't think any of these searches is perfect, and they can be like finding a needle in a haystack sometimes. However, some of the options that I want to put out there, and I'm hopeful that somebody can share this afterwards with you, is first of all, there's a government website, clinicaltrials.gov, and you can search for your cancer kind and location. So this is, all across the nation. I mentioned Cancer Research Institute is an institute that was founded by William Coley's daughter and has persisted on since then. So this CRI actually has a website as well, and they have a search function to look for immunotherapy specific trials if that's something that interests you. And then of course, your local cancer center, I put our website up here, and patient organizations like this one. So many patient organizations can help navigate this as well. So to recap about colorectal cancer and immunotherapy, I really talked a lot about those two main kinds of colorectal cancer, MSS and MSI, explained that MSI has many mutations, and that's what helps it respond to immunotherapy. However, the other thing I didn't say yet that I'll point out is it's only a 50% response rate. So only 50% of tumors will shrink or have some benefit. And we still don't have a perfect answer there. So that's actually another area of research is how can we get 100%, from 50%? How can we make that better? And then for MSS, unfortunately, there are no approved immunotherapy options right now, and clinical trials are one way to explore immunotherapy. The other thing I want to say though is that clinical trials are not, they're maybe not the best option depending on timing. So, if there are other options out there that make sense for a patient, like things that are tried and true, like chemotherapy that we know has a response in a certain number of patients, even coming to a clinical trial clinic like ours, we would recommend that you try those treatments first. I think it never hurts to look and see what's out there, but it also is sometimes a matter of the right time to try something. So now I'm going to move on for the last part of the talk, hopefully leaving ample time for questions, to talk about different types of cancer immunotherapy. I've already talked about a couple of these during the talk, and now I'm going to dive in a little bit and explain how some of them works. And for some, I'm also going to talk about side effects. So there's actually many, many ways to try to use the immune system to fight cancer. When I say immunotherapy, this is not one drug. This actually is not even one type of therapy. This could actually be a pill. This could be an injection under the skin. This could be an IV medication. So these work very differently. One way is a cancer vaccine. So this is based on many years of technology. We've seen amazing things with vaccines in the past 2 years. I don't think I have to say that about how much press vaccines are getting right now. And it's because we've been able to make these so successfully for infectious diseases over the years that we're trying to take that technology and apply it to cancer. And just like we have many different ways to make a vaccine against COVID, for example, there's some that are using viruses, there are some that are using mRNA. There are many different ways to do this for cancer as well. And so some of the examples here on the left-hand side, I'm not going to have time to explain how all of these work, but I will say that we have to, when we're making a vaccine against cancer, we have to decide, are we going to take a couple different mutations from a cancer and try to make a vaccine against that? Are we going to pick one mutation? And again, this comes back into play when we think about how individual of a disease cancer is. Everyone's tumor is a little bit different. So we actually have to decide and be strategic. Are we going to try to make a vaccine that would work for a lot of people, or is it going to be a personalized therapy? And there are pros and cons to both approaches. There are also different ways to deliver a vaccine. I also already kind of alluded to that. We can give an injection into the skin or via a vein, and we can use different things like viruses or mRNA or protein to help deliver this as well. So there's a lot of different strategies here. This is not to dive into any of them, but just to give a sense that vaccine is a pretty broad type of technology that covers actually a lot of different types of treatment. And then also, because a vaccine is used to jumpstart an immune response to cancer or bacteria or virus, it can actually be used in combination with other treatments. So we could think about combining it with something like radiation or one of these immune checkpoint inhibitors that I'll talk about soon. So that's actually the next thing I'm going to talk about. And this is an area where some people may have actually heard of these, because when I showed that initial slide about all the different kinds of approvals we've had for immunotherapy over the past 20 years, many of these are actually for immune checkpoint inhibitors. And the other way that people may have heard of these is a term called monoclonal antibodies. So this, if you see this MAB at the end of the name, that's a hint that it might be one of these checkpoint inhibitors, because they're all antibodies. Remember when I showed that slide of the B cells, they make these proteins called antibodies. And I said they're very good at binding. They're a protein that's very good at binding to other proteins. So what the protein can do is it can bind to different cell surface proteins on T cells, as you see on this cell here, or on tumor cells, like over here. And it can either block an interaction between two proteins, or it can also try to stimulate an interaction. So we're really taking advantage of antibodies, which our bodies naturally produce, and we're kind of just using them as a tool. We're modifying them. Companies and labs have modified these to bind to particular signals from tumor cells or from T cells, which are immune fighter cells. And it turns out that tumors have a lot of different ways of trying to evade or get away from the immune system. They put up some negative signals. One of these negative signals is called PD-L1, and it binds to this protein called PD-1 on a T cell. Another protein here that's a negative signal to T cells is called CTLA-4. So these are different targets of these whole class of drugs called checkpoint inhibitors. So again, kind of complicated topic, but I like to think about when I describe these checkpoint inhibitors to patients is that we're blocking a negative signal. We're allowing the T cells to become more active against cancer. The checkpoint inhibitors, have now been around for 15 to 20 years for approved for different tumor types and approved for MSI high colorectal cancer. And so we're learning more about their side effects. I already talked a little bit about side effects that can happen. And I'll just go back over this quickly again to talk about this idea, is that there can be these non-specific side effects like feelings of fevers, chills, fatigue, but the more common or the more concerning thing we see with these is a very specific kind of immune response against your normal cells. And thankfully, this actually doesn't happen in the majority of patients. I'd say this happens in about 20% of patients or less. And a really severe immune-related side effect usually happens in about 5% of less or patients that have been treated with a checkpoint inhibitor. And again, examples of this this slide is a little scary because it kind of lists everything and everything under the sun, but that typically doesn't happen in most patients. And when it happens, it's usually just one organ or cell type that's affected, usually not all cell types. One example, just kind of the list I already talked about, like if your colon's affected, you could have colitis and diarrhea. Another example is if your thyroid gland is affected, you could have hypo or hypothyroidism, which usually just manifests as fatigue and changes in heart rate, things like that. There are ways to treat these. So usually we stop giving the checkpoint inhibitor. Sometimes we have to give a drug like steroids to calm down the immune system. But sometimes we can actually continue treating people when they get this thyroid problem. We can usually treat the thyroid problem by itself and continue treating the cancer if the immunotherapy is working. So it's always a judgment call there when patients have side effects, whether it's something we can deal with and keep going, or we need to be safe and stop treating. So those are just, again, side effects. And unfortunately, we don't have good ways yet of predicting who will get those side effects. The next kind of therapy I'm going to talk about is an oncolytic virus. And so this is taking advantage of the fact that viruses infect our cells, and sometimes they can actually break open the cells, in the process killing them. So obviously we want something to infect a cancer cell and break it open and kill it. But the other good part about this is when the cancer cells die from the virus, they actually are kind of putting up these red flags, these signals to the immune system saying something abnormal is taking place here. The virus is an abnormal signal as well. So it brings in a lot of immune cells and it generates this immune response. So it kind of does two good things. It's killing the cancer cell and it's also initiating an immune response. The reason that we can use these safely is that we can engineer the viruses so that they only infect cancer cells and they're safe for normal cells. And the other thing we can do is actually, because cancer cells are so focused on growing and invading organs, they've actually lost some of their normal cell functions. They've lost what I would call their antivirus software. So they actually are able to be infected and killed by virus cells when normal cells may not be able to. So there's a couple different ways that we can actually take advantage of that. But the end goal is that we have this immune response that's been orchestrated or initiated because of the virus. There are a couple examples of how those have been used mainly in melanoma, but again, not approved yet in colorectal cancer. So I'm going to move on and keep talking about other kinds of therapy. The last kind of therapy I'm going to talk about is, I think, the most complicated. This is using our body's own cells, taking them out and then modifying them or engineering them and giving them back. And this is an example of, so CAR T cells are one example of cellular therapy. And that CAR T cell might be what people have heard the most about in this class of drugs. The reason why you may have heard of these is because they've been around for probably about 10 years, using them to treat things like childhood leukemia and in adults, lymphoma and myeloma. These are all kinds of blood cancers, and they work very differently to defeat a blood cancer than they were going to have to defeat a colorectal cancer. But because this idea has worked so well in blood cancers, we're now trying to take advantage of that technology and make these cells work to treat colorectal cancer and all other solid organ tumors. So to talk about the way that it works, I have this diagram. The first step is we need blood sample from patients to get the T cells out of their white blood cells. We then send these to a company or a lab at a university, and they modify the T cells. And they modify them with receptors that can find and then bind to and kill cancer cells. One example of the kind of receptor that we might engineer in is this thing called CAR. So that's where CAR comes from. It has nothing to do with driving. It stands for chimeric antigen receptor. And essentially it's sort of like a modified, an engineered receptor that we've figured out will bind to cancer cells. Once that receptor is in the T cell, they grow up many, many, many T cells. Because the issue is that sometimes, our body does have these immune responses to cancer already existing, but the cancer is winning the war. We don't have enough of the T cells. So we need to give the T cells in high numbers back to patients, and then they can find the cancer cells and kill them. Again, this idea has worked really well in blood cancers. We don't know how well it's going to work in cancers like colorectal cancer, but it's in clinical trials already. There's actually a couple different ways to do this cellular therapy. I won't go into detail as much as I did for the CAR T cells, but I just want to say that there's different kinds of receptors. One is this kind of receptor called CAR. Another one is called TCR or T cell receptor. So there's different ways to take these blood cells out of circulation, modify them in a lab, put them back into a patient after we've grown many, many of them. The other thing that's possible is this therapy called TIL therapy, and TIL stands for tumor infiltrating lymphocyte. What it means is that these are the T cells not just from the blood, but from inside a tumor. To get these, we either need to do a surgery or a biopsy of the tumor, take out the TILs, grow them in the lab, and give them back to the patient. The last important point about all these kinds of cell therapy is they actually require conditioning the chemotherapy. And this chemotherapy is not directed at killing the colorectal cancer tumor. It is directed to actually make space for the new T cells that are going into the bloodstream. We actually want to decrease the white blood cell count, which is one of the unfortunate side effects of chemotherapy that patients often have to deal with. But in this case, we actually want to do that temporarily so that when we deliver these T cells into the blood, they have the best chance they possibly can of staying and growing. One of the side effects of giving these cells, whether they're T cells or the TIL therapy or CAR T cells or TCR T cells, is that when they go into the body in these high numbers, they can release these things called cytokines. Cytokines are inflammatory mediators. They're the kind of things that make us feel sick when we get a fever. And so they can cause things like fevers, chills, low blood pressure, fast heart rate. These effects are usually temporary, and we can resolve them with medications. But because this therapy is new within the past 10 years for blood cancers and very new for other kinds of cancer, still in clinical trials, a lot of these trials are actually requiring patients to stay in the hospital for a couple days at least, more like a week sometimes, when they get the therapy. And that's just to monitor them for this syndrome called cytokine release therapy. The last therapy I'll talk about, just one more bonus, I think I thought I was done with the cellular therapies, but I included this one, which is another new treatment that's been in clinical trials, is something called bispecific antibodies. So remember, antibodies are this thing that binds to other things. It's very good at sticking onto things. And so we can take advantage of that by engineering it to bind to multiple things at the same time. And one of the ways that's been used is to bind to an effector cell, like a T cell, the immune fighter cell, and to bind to a cancer cell at the same time. And what happens when that does that is those two cells now are very close together in the body, and the T cell has a better chance at killing the cancer cell. It also can have some side effects like the cytokine release syndrome, because the immune system's very activated all at once, and it might release these inflammatory mediators or cytokines. So things like fevers and chills and low blood pressure can happen, usually again temporarily. And we give these therapies through the IV or under the skin. So that was a lot of information. There's a lot of new directions this is going. I hope that wasn't too much, but to take a step back, we talked about the many different strategies and kinds of immunotherapy there are. We talked about vaccines, oncolytic viruses, immune checkpoint inhibitors, different kinds of cellular therapies. Again, I didn't get a chance to go into this too much because it's pretty complicated, but one of the considerations for any of these, but especially for cell therapies, is that these might have to be personalized because of different HLA types and different people. So there, I'm going to end my talk, and I see that there's a lot of questions in the chat. I haven't had time to read those because I've been talking, but I welcome any questions now.
Yeah, Dr. Keenan, great talk. Thank you. You covered a lot. It was excellent. So I think I'll start with the questions. The ones that had emailed you about the tumor microenvironment. There is a lot of interest in immunotherapy for CRC, but the issue seems to be that the response, for example, in the liver is much muted. So we have not got that kind of response. So could you comment something about the tumor microenvironment in different organs, how that might affect immunotherapy?
That is a really good point. So this is something that's being studied right now, and a lot of different discoveries have happened in another cancer type called melanoma, where melanoma is actually one of those cancers that the checkpoint inhibitors are approved in, and they work really well. But what cancer doctors have found is when patients have a metastasis of the melanoma to their liver, the checkpoint inhibitors don't work as well. So that led to a lot of studies in mice and in the lab using patient tumor biopsies, showing that there are changes in the liver that actually lead to a lower response. So it could be the same cancer, but if the cancer moves to a different site, it can have different properties. Because colorectal cancer has a high chance of metastasizing to the liver, so it can, it can metastasize anywhere, but one of the common sites is the liver. That's a big concern for colorectal cancer patients and using immunotherapy. That could actually be one of the reasons that response rates are lower. And that is something that is very active area of research, is trying to figure out why that happens when there's a liver metastasis, and also what could we do about that.
Okay, thank you very much for that answer. There were some questions. So one of them was so there are some trials where people are trying radiation on top of immunotherapy and then combining it with chemo. So one question was, do you think that is additive, synergistic, or just dangerous? Like, what is your advice on it?
Yeah, so that's another good question and an area of research is there's a thought that using radiation could be really helpful with immunotherapy. The reason why is radiation and even chemotherapy, to some extent, this might work with chemo as well, is it is directly killing cancer cells. Remember, immunotherapy, one of the things I should have said about it is indirect therapy, right? It's acting on the immune cells that then go and kill the cancer. Chemo and radiation, why they're so different is they're directly killing the cancer cells. So when you kill the cancer cells, they can kind of burst open and then the immune cells come in to do the cleanup job. And if the immune cells at the same time are being activated by an immunotherapy, whether that's a vaccine or a checkpoint inhibitor, and radiation is happening, there's a thought that those would work synergistically, meaning they're working better together than either does on their own. And that's because the radiation kills the cancer cells and the immune system comes in as a cleanup job, and then the immune system also is being activated. So all of that happening at the same time might help them work together. Safety is always a concern in any clinical trial. So far, we don't think that because the side effects of immunotherapy are so different than chemo and radiation, there obviously is a chance that with any therapy you have side effects, and then you could experience side effects from one and at the same time side effects from the other. But there's no reason to think that those side effects are necessarily interacting, that they're going to make each other worse. That obviously there are risks to each therapy, but together the risks shouldn't be worse than either therapy on their own. So far the idea seems generally fairly safe as radiation is in general.
Okay, thank you very much. So more questions. I'll start from, so everybody really loved the presentation and you're great at explaining complicated things. So thank you very much for that. So one question is about neoantigen vaccines. Especially, what makes them good vaccines? Like, how do people decide which antigens are best among the neoantigens? Like, if you could say something.
Sure. So this is, a good question about vaccines. So first of all, I want to define what antigen is. Maybe not everyone knows, and I stayed away from using that word because I didn't know if people would recognize that. I used words like mutation or protein. So what an antigen is that, remember when I talked about that part of the particle or cancer mutation that's being presented to the immune system? That's what the fighter T cell sees. So that is basically what the antigen is. It's that particle that the immune system sees and recognizes. Neoantigens means that these are particles that don't exist in our bodies except in cancer cells. So we want to pick a neoantigen, not just any shared antigen, when we're figuring out how to direct a vaccine. We want something that looks different than a normal cell. So when cancers mutate, the proteins that result of the mutations they can look different. They can look different to the immune system. So that's what that neoantigen is. That's why a neoantigen might be better than something that's the same for a lot of reasons. For one, for safety, because you don't want an immune cell to target a normal cell. But you also, the other reason is to how well it works. You want to pick a neoantigen that's something that's very different, that the immune system is going to recognize as specific to the cancer cell, and is going to have a very strong response against that. So that is kind of one consideration about how to make a vaccine to a neoantigen. And then of course, there's lots of different technical ways to think about how we're going to do that. And again, this is like my point about, could we make an mRNA or a protein vaccine without going into too much of the details of that. But I do think that's something that people are hearing more about now, because there's all this discussion about the different COVID vaccines and how they made those. So something people are hearing even more about.
Okay, thank you very much. So the next question is, for MSS patients, what immunotherapy plus a different combination, whether it's chemotherapy or targeted therapy, what in your opinion do you think is giving better results?
Sorry, I missed the last part of it. What
meaning what kind of combination for MSS patients, immunotherapy plus what else is giving better results?
So I think the short answer is we don't know, but there are a lot of possible combinations out there. The one I talked about was regorafenib, which we actually think about, and we sometimes put it in the category of chemotherapy, but also we sometimes call it targeted therapy because we know it not just non-specifically kills cells, but also hits a couple different proteins. So we call it a targeted therapy. In a lot of other cancer types, things like kidney cancer, for example, liver cancer, there have been really good success pairing some of those targeted therapies, so things like regorafenib plus immunotherapy. So I do think that that is a promising angle. In other diseases like lung cancer, they've actually had more success pairing things like chemotherapy and immunotherapy. And one of the reasons for that, again, is that if you're killing cells and breaking them open with chemo or radiation, you might help the immune response to act on those cancer cells. It might be sort of that red flag that we need. So I think either chemo or targeted therapy or radiation, those are all avenues. And I would suspect that there are trials going on for really any and all of those. I know at our university, our GI cancer group is running a study looking at a couple different things in combination together. It's looking at a molecule that actually inhibits blood vessels called bevacizumab, and then in combination with a chemotherapy and an immune checkpoint inhibitor. That's just one example. So I'm pretty sure that at most big cancer centers in the US, you're going to find a trial that is looking at different combinations, and right now we don't know which one is best.
Okay. And the next question is, what factors or determinants are used in order to personalize immunotherapy to make it more effective?
I think there's a couple different answers to that. So one of the things I didn't talk about is what other factors besides MSI and MSS could actually help us determine who will respond to immunotherapy. We know that the responses are very low in MSS, but they're not zero. So there are some patients that might respond to checkpoint inhibitors. And what we've seen a couple very small, these are just like one patient here, one patient there, nothing that has led to a big study or a big approval yet, but is patients that have different mutations. So one idea is patients that have a BRAF mutation, their cancers might be more immunogenic, but we don't know yet if they respond better to checkpoint inhibitors. That part we don't know, but there is some thought about the biology of those tumors might be different. The other thing is mutations in pathways like DNA damage repair outside of the 4 proteins that we already know make up the MMRD or mismatch repair deficiency pathway. There's some other proteins, one called POL, for example. Those are involved in copying and proofreading the DNA. So those again are other DNA mutations we might look for to try to personalize therapy. But because we don't have approved options yet, it's hard to look at somebody's report of the mutations, things like people are, many patients are familiar with things like Foundation 1 testing, right? Those reports of molecular changes in the tumor. We don't have a good way of looking at that report yet and deciding who will respond and what therapy they should get.
Okay, thank you very much. I think we are past time, so there are more questions. What I'll do is that maybe I'll email them to you and then I can share the replies with people. That might be better. And so thank you very much. This was great. And yeah, I'm going to post like a screenshot on Twitter, and I think that I hope that's okay. And thank you again.
Yeah, that's great.
Thanks a lot.
Okay, I really enjoyed it, and I hope that was helpful. Take care.
You too. Thank you. Bye.
Bye.